the collection of air in the space between the pleura and the lungs. Untreated, this can lead to a complete lung collapse. Some of the causes of thoracentesis: RDS, meconium aspiration, surfactant deficiency, spontaneous air leak, and there's sometimes no rhyme or reason, it just happens. If they did x-rays down in the nursery, you would find that many kids have spontaneous small pneumos that don't bother them. PPV, CPAP, mechanical ventilation, and this is something that happens as a result of treatment that we do, but it's just, it happens. Congenital anomalies. Typically, the congenital anomalies have pleural effusions, the fluid more than the air, and we might get a heads up if it's a congenital anomaly that that's something that there is. The pleural effusions are fluid that collects in the pleural space. And this one is large bilateral pleural effusions. So, assessment findings. If you have chest asymmetry, just physically, like one side looks bigger than the other, enlargement of the effective side, and not always and not all of them. Sometimes it's kind of insidious. It's a slow leak. Unilateral breath sounds. That's pretty. When you don't hear breath sounds at all, there's something wrong, and you probably have other issues going on. Shift of point of maximal cardiac impulse, PMI. So that's done typically after there's been some air evacuation, because it's very common for it to reaccumulate. So what you would do is listen for the loudest area on the chest for heart sounds, put a piece of tape with an X, and each time you do your assessment, you listen, and if it's shifting, if it's moving over, likely there is more air accumulation. And you tell the doctor. The most, if you're suspecting a pneumo, the first thing they're probably going to want to do is transilluminate. Does everybody know where that transilluminator lives? Because the docs really prefer that. Do you know where that is, Kelly?
Yeah, on top of like where the TCV.
It like behind the code cart where the respiratory stuff are. It's plugged in there.
Next to the laundry cart.
Yeah.
To the left. Oh.
It's kind of an antique, but they really love it. It really brightens the chest. It's kind of finicky. It has to be plugged in to work, but it has to be unplugged to use. So they're going to ask to grab that. In reality, anything works, even a pen.
Even by the bedside has to be plugged in for.
No, not plugged in at the bedside. Plugged in to be charged.
Okay. Yep. Okay.
The little purple transilluminator works. A pen light works as long as the room is dark, but they like that to really see how big it looks. The definitive diagnosis of a pneumo is absolutely by chest X-ray, but if the kids are symptomatic and you see this, they're just going to needle first. This is an X-ray of a tension pneumo. Tension pneumo is a very big medical emergency where large pneumothoraces, because you can get more than one, produce sufficient pressure to cause a total collapse of the lung. And this is the pleural effusion, like I said earlier. So, in the delivery room, and this is interesting considering the events, you want to consider a pneumo if you have a full resuscitation and you're at 100% oxygen, baby is intubated, chest compressions, and nothing is making the heart rate rise. It could be a pneumo. They would just maybe transilluminate, maybe not, because at that point you got to do something to get that heart rate up. But I think we're all trained in NRP to think of corrective actions and the chest compressions and intubating, all that. So, but it could be a pneumo. So if you're in that situation, the code cart would already be there. We don't have the little boxes that you guys have upstairs. So in drawer 3 is IV and pneumothorax supplies, which is not in the little baggies that you have upstairs. So you'd have to grab it. So what are the MD steps? Brief timeout to confirm correct side to aspirate. And I know that sounds so simple, but things happen. Limbs have been removed from the wrong side of people, not in our unit. So you want to absolutely say, are we doing the correct side? Because especially in emergency, everybody's looking this way, that way. The MDs have 2 sites to choose from, and this is their choice. 4th intercostal space at the anterior axillary line. This is a picture of a normal infant rib cage. So 1, 2, 3, 4, and it's at the axillary line, which would be like around here. So it would be above the bony part of the 4th intercostal space. There is a lot of blood supply and nerves there. So if they pull back and there's blood, they need to new setup, start all over. And then the other one is the 2nd intercostal space at the mid clavicular line. So rib 1, rib 2, and it would be somewhere around there. And I just think it's important to know where that spacing is in case
Landmarks. Yeah.
landmarks, in case, I mean, we're never doing that, but we have so many people, in case you felt they were really low down or really high up, you may want to just give a gentle nudge, like, do you want to move your needle a little bit? So some risks to think about: lung injury, bleeding, infection, bradycardia, oxygenation changes. So what is your responsibility as a nurse? So the doctor just does the procedure, you do everything else. You're gonna gather your supplies, 23 gauge or 25 gauge butterfly, 3-way stopcock, 20, 30, or 60 ml syringe, and it doesn't matter what size butterfly or what size syringe. If it's a really large pneumo, you're gonna keep pulling the air out. Whatever you can safely grab, because it is an emergency. Betadine and alcohol swabs, 2x2 gauze, and Band-Aid. The baby should be positioned with a small blanket roll so the affected side is up. That's why it gets kind of like, do we have the right side? This allows air to rise to the chest so they can evacuate better. Monitor heart rate, SpO2, cycle BPs every 5 minutes. Grab your friends, prepare for rapid deterioration because you really don't know if it's going to work. So somebody should be a documenter and somebody else should be setting up chest tubes and intubation. How the stopcock works, and we're gonna practice. The arrows point to the port that is off, that is closed. So the arrow towards the baby means it's closed. Arrow away from the baby means it's open. Critical safety point: you never want to push air back towards the baby. And the stopcocks they're simple, but it's in an emergency and you can barely see it, and the doctor is not touching that at all. So, always turn the stopcock to close from the baby when removing air from the syringe. And this is just a picture of the procedure being done. And you guys want to practice? Do you want to set up the stopcock, or just pretend you did?